Hello and good day to you all again. Navid from Edinburgh Endodontist here. Hope you're all well. Welcome back again to those of you who watched the previous um, episodes of these short lectures yesterday and the day before. Hope you found these helpful so far. Today I'll cover enamel-dentine fractures, also known as uncomplicated crown fractures. As you may recall, we are covering dental trauma over 2 weeks, one type of injury per day. We are splitting them into fracture injuries and luxations. This week is fracture, and next week luxations. We discussed the aims and learning outcomes in the first talk, which appears under infractions. If you want to go and watch that clip, it will be helpful. We also talked about the importance of time in prompt and appropriate management of traumatic dental injuries. The etiology was covered in the first clip as well in this series. For those of you who missed it, you can find it again under infractions. Please watch those clips as well, and preferably first before this one. It helps a lot. This week we go through fracture injuries, and today we talk about uncomplicated crown fractures known as enamel-dentine fractures. These fractures are also known, as I said, uncomplicated crown fractures, as they do not involve the pulp. They involve both enamel and dentine, but no visible pulp exposure can be seen, okay? Patients usually complain of sensitivity to cold as the dentine is exposed. They are not mobile and are not tender to percussion. If you detect mobility and tenderness, think luxation, okay? Which we will cover obviously next week. Radiographic examination reveals that tooth substance has been lost, and you can confirm it. You've already seen it clinically, but you can get a confirmation radiographically. The root and periapical tissues and socket should be normal and intact. If you think luxation has happened, take multiple angle periapical radiographs to detect it and document it and examine it. Also remember, full clinical examination must be carried out no matter what, as we've discussed already, and soft tissues must be thoroughly assessed for lacerations. Take photographs as well, please. Do not forget that. If the broken fragments have not been found, check the soft tissues and take lip and soft tissue radiographs, as discussed yesterday in the enamel fracture clip. Please watch that clip as well if you have not done so already. For management, it doesn't matter now anymore whether it's a primary or permanent tooth. You can restore with direct composite resin straight away if the fragment is not available. Otherwise, it's always better to bond the fragment back. This is the best approach, the preferable option. If you've got the part of the tooth that has been detached, try to bond that back. If you cannot bond it back, if you don't have time, if you don't have access to composite, please cover the exposed dentine with glass ionomer bandage restoration. At least do that. Don't let patients go without any treatment. At least if you don't have time, please put a bandage restoration with glass ionomer. This will temporarily reduce the sensitivity and also reduces the risk of bacterial contamination. Remember, now the dentine is exposed. So it's not just a little chip on the enamel. You've got the tubules exposed, okay? So there is risk of pulpal contamination. So make sure that you cover these as soon as possible, but also before you do your bonding, make sure you decontaminate the surface with sodium hypochlorite, okay? You can then monitor in 3, 6, and 12 months using, the clinical and sensibility testing in 3 months and introduce a radiographic assessment in 6 and 12 months as well. So to sum up, And the recap, so far we've covered infractions, which don't really need much doing to them, just need reassurance and annual follow-up. Enamel fractures that we talked about yesterday, they need either smoothing down, reattachment of the fragment, or build-up, an annual review. And finally, as we've just covered today, enamel-dentine fractures, they just need either a reattachment, or if not possible, build up with composite, or at least if there is no time, provide a bandage, glass ionomer restoration. The review is now 3, 6, and 12 months because you've got a risk of pulpal contamination. Keep the 3 months for clinical and sensibility testing, and then 6 and 12 months, you add the radiographic assessment as well. And again, what you're looking for is, pain, swelling, discharge, mobility, signs of apical radiolucency, signs of resorption. You just need to go through all of these systematically and rule them out. Okay. This is the end for the enamel-dentine fractures talk. I hope you've found this helpful as well. Tomorrow we will go through enamel-dental pulp fractures, the complicated crown fractures. So it's getting more and more serious. Please check the dental trauma website and the members area as well. We will go through the rest of the types of fracture injuries tomorrow and for the rest of the week. We'll speak with you tomorrow. Stay safe, take care, bye for now.